Good afternoon, everyone. This is the third session in immune suppression. I hope to finish immune suppression today, but I think it needs further sessions. So today I'm going to highlight the most important drug-drug interactions with immune suppressive drugs. And the key message is, whenever we use immune suppressive drugs, we should be smart, looking at not only the immune suppressive drugs, but the concomitant drugs used, because there is real interactions. And nowadays, we are lucky because we have tools to help us to know if there is interaction or not, and how to deal with these interactions. Through the coming, I think I'll take 1 hour and 20 minutes through this presentation with discussion, and then leave 30 minutes to Dr. Ahmed to present some hot issues. So I'm going to highlight the importance of drug-drug interaction between COVID-19 and immune suppressive drugs, and then the antimicrobial drugs used and drug-drug interactions, and the very hot issue of metabolic profiles, including management of diabetes and dyslipidemia and the interaction with immune suppressive drugs. Few points about gastrointestinal tract, and I'm going to highlight chronic diarrhea and how to deal with immune suppressive drugs. Few points about reproductive health and immune suppression. Bone pain, if we have bone pain in transplanted patients with immune suppression, how to deal. Few miscellaneous and one slide to conclude the presentation. Let us start with COVID-19, because we are living in this disastrous infection pandemic all over the world that affect everything in our life. To start with, I'd like to start with this case. This case highlights that some of investigational drugs that may be used, although the evidence is very weak if there is an effect. Lopinavir, ritonavir drug combination therapy for treating COVID as antiviral drugs, that the mechanism of action was highlighted by Professor Kossi in one of the ESNT presentation. But today, I start with this case because using lopinavir, ritonavir in a patient maintained on tacrolimus leads to very high level with toxicity. That's what I said effect. A level of tacrolimus reached 90 nanogram per milliliter. So this is heroic to level of tacrolimus, and this shows how these drugs interact with immune suppressive drugs. This is why I presented this article, and I'm going to highlight some tables from this article. This is a very recent article, shows pharmacological treatment of transplant recipients infected with COVID-19. And the main focus of this article is consideration regarding therapeutic drug monitoring and the drug-drug interactions. So let us take it one by one. So if we look at hydroxychloroquine, nowadays I am totally against the use of hydroxychloroquine to treat COVID-19. But many people worldwide use hydroxychloroquine as a treatment or adjuvants for treating COVID-19. If we use hydroxychloroquine, it is recommended to evaluate the cardiac status of the patient. ECG is mandatory before hydroxychloroquine because hydroxychloroquine may be associated with QT interval prolongation. And prolonged QT means that there may be a risk of fatal arrhythmia. So for hydroxychloroquine, either the patient is treated with tacrolimus or cyclosporin. The interaction is moderate to major with tacrolimus and moderate with cyclosporin. And the key message is QT interval monitoring is required before prescribing hydroxychloroquine. For these drugs, lopinavir, ritonavir, which is known as Kaletra, darunavir, which is Prezesta, and darunavir, Kossi stat, which is Rezolista. These three types of drugs are associated with major interactions with tacrolimus and cyclosporin. Look here at the recommendation. Consider tacrolimus dosing to regimen to be reduced into just 0.5 to 1 milligram once weekly. So this is immediate release tacrolimus to be given only 0.5 milligram per week when we use one of these antiviral drugs. To be cautious. And for myself, I'm very afraid if there is any rule of these drugs, I think there is no significant rule. And if this is the interaction, it is better not to combine these drugs with either tacrolimus or cyclosporin. So this is the situation for tacrolimus, 0.5 milligram to 1 milligram per week. For cyclosporin, 25 milligram every week, every 1 to 2 days. So this is drastic reduction of cyclosporin as well. If the evidence is very low for the efficacy of these drugs against COVID-19, why to use them? For favipiravir, remdesivir, tocilizumab, all these investigational drugs, the information is not available for the interaction with tacrolimus and cyclosporin. With mTOR inhibitors, we can expect the same. These drugs are associated with inhibition of the metabolism of everolimus and sirolimus. So it is major interaction, increasing everolimus level, and this may result in increased risk of everolimus toxicity. So consider weekly dosing interval and close therapeutic dose monitoring, and it is highly recommended to follow this. This is the same with everolimus and the same with sirolimus. For hydroxychloroquine, the interaction is low, but again, ECG is recommended before prescribing hydroxychloroquine because we are afraid of QT prolongation and subsequent arrhythmias. For mycophenolic acid, there is no significant interaction with hydroxychloroquine or other antiviral drugs. But if we diagnose COVID-19, the first step that the majority of transplant physicians do is to stop antiproliferative drug and stopping mycophenolic acid producing drugs, either MMF or mycophenolate sodium. For prednisone, no interaction with hydroxychloroquine. Again, QT interval monitoring is indicated. For lopinavir, ritonavir, there is major interaction with cortisone, increasing steroid that may lead to Cushing syndrome. So we should put all these in our mind. One of very interesting commentaries of the Nature is this implication for immune suppression in kidney disease and transplantation, discussing many issues about COVID-19 and immune suppressive drugs. By the way, COVID-19 is associated with inflammation, associated with maybe associated with hypoalbuminemia. This means that the environment of inflammation affects the pharmacokinetics and the volume distribution. Moreover, if we have cytokine activity, this may reduce cytochrome system and reduce metabolism. So there is from the pharmacological point of view, there is rationale to consider drug-drug interaction. If we have a case, transplanted case, and we diagnose COVID, what is the outcome and how to deal with the case? The outcome is in transplant patients, this is some of the series. If we look here for this 36 cases, 28 patients were hospitalized. Renal replacement therapy were requested in 6 out of 28 of hospitalized patients. So renal replacement therapy is needed in 21%, and mortality in 28%. So the prognosis is not good, it's bad prognosis. And the how to deal with immune suppressive drugs. As we do for any infection, the starting point is to stop anti-proliferative drug. So stopping anti-proliferative drugs, mycophenolic acid, azathioprine, and for mTOR inhibitors, all of us know that mTOR inhibitors may be associated with pneumonitis. And here, COVID is associated with pneumonia. And sometimes it is difficult to discriminate between COVID-associated pneumonia and pneumonitis associated with immune suppression. This is why it is better to avoid both anti-proliferative and mTOR inhibitors as well. Then if we have severe disease, we stop calcineurin inhibitors. What about steroid? It's better to reduce steroid dose, not to exceed 30 milligram, because if we exceed 30 milligram, this will increase viral replication. So it is better to be even less than 20 milligram. So you'll find here the experience of different centers showing the same principles: to stop anti-proliferative, to stop all immune suppressive drugs if the patient is suffering from severe disease. I'm not going to discuss the case reports, but if you remember last week, when we had in the poll and the voting, which immune suppressive drug may reduce the viral replication, and the answer was distributed among different choices, but from experimental animal model, cyclosporin decreases the expression of N protein, human coronavirus 229E. This is multifunctional protein that is needed for viral replication. So there is theoretical background showing anti-COVID effect of cyclosporin. To the extent some authors thought, is it wise to shift from tacrolimus to cyclosporin in the era of COVID? Up to this moment, there is no evidence for that, but this is an experimental work showing cyclosporin may reduce viral replication. Let us go to a drug that is not available in Egypt, which is belatacept, which is costimulatory blockade agent, biological treatment, used instead of calcineurin inhibitor. And it is given through intravenous infusion. So it is given monthly infusion. And if we are living in COVID era, how to allow the patient to come to the clinic, to the hospital every month for infusion, and we advocating distance medicine and telemedicine. So this is a quite problem. So there are many authors thinking to shift from belatacept to oral drugs. And this is an experience from French center. They had 113 organ transplanted patients. The majority kidney transplantation, 102, and 11 cardiac transplantation. And they applied a strict rule for infection control, and they succeeded to maintain belatacept. And one of interesting note is that they found cytokine release syndrome is not so severe with belatacept. Why? Because belatacept as co-stimulating blockade may reduce cytokine storm. As I mentioned, COVID-19 affects our practice. Yes, here at Urology and Nephrology Center, this is the total number of transplant that we have. But unfortunately, from 11th of March, we stopped transplantation service at Urology and Nephrology Center. Since 2 days, we sit together to discuss when to resume transplantation in era of COVID. But when we look at the rate of infectivity in Egypt, and in the last week, the curve was rising and is still rising. So we decided to postpone renal transplantation and to readdress discussing this point after 2 weeks. I think I'd like to refer here to hear from you any comments about COVID-19 and immune suppression. We start with Dr. Halawa and then Dr. Kossi. Dr. Halawa.
Yes, actually, it's quite clear that hydroxychloroquine is not a drug to be used in COVID-19. So this chapter is closed.
Yes.
So I don't think there's any merit of addressing it again, because it may give impression that we agree in one of the drugs which is still used. I mean, it shows some harmful effect as well. So it could cause disaster in terms of cardiac abnormalities. Also, we have experience with anti-HIV drugs, ritonavir. It is a very tricky drug. The HIV patients we have, you know what dose of tacrolimus they take? 0.5 milligram per week.
Yes.
Not per day, not twice daily. 0.5 milligram per week, because it's very strong potentiating drug. So again, it's proved to be ineffective in COVID-19. So it's what we are getting here, the side effects. And you mentioned tacrolimus level of 90. 90 actually can cause, damage to the kidney and also toxicity, neurotoxicity.
Yes.
So we are killing the patient with side effects. So, I'm glad that you mentioned that these drugs are not effective. We have to make it clear to our colleagues that these drugs even shouldn't talk about it, in COVID-19.
There is a very nice evidence-based review that was published a couple of days ago, confirmed low evidence if there is any benefit of these drugs. It may be a remdesivir because it is still used. And although we say this, that these drugs are ineffective, you will find persons who are using these drugs. This is why I'm stressing upon the side effects of using these drugs. Dr. Kossi.
Yeah.
Oh, thank you very much, Professor Hussein, for this nice talk. To be honest, I mean, I would like to be more specific in the terms that we are talking about the hydroxychloroquine and the other protease inhibitors, lopinavir, ritonavir, danavir. First of all, about the hydroxychloroquine, still we don't have the clear answer as yet for a good evidence. What we have got is an observational studies. Yes, it is 96,000 patients. 15,000 of them, they have taken the hydroxychloroquine. They showed some sort of detrimental effect. Whether this is, a good evidence or not, we don't know. So probably we can put it in this way. Yes, hydroxychloroquine shouldn't be given, but within the context of a clinical trial, randomized clinical trial, we would be able to know whether this drug is effective in prophylaxis. We can conclude something beneficial. So this is the standard. But to be honest, so far we don't have any clear evidence to say that the hydroxychloroquine is detrimental from a good quality evidence. So within the context of clinical trials, yes. Outside the context of clinical trials, no. And obviously within the context of clinical trial, you have got this QTC interval prolongation should be very carefully looked at. Definitely, like say for example, azithromycin is known to prolong even more the QTC interval, so it shouldn't be given with it. So all this can be addressed. And probably we need to be very clear about this statement. Lopinavir, ritonavir, as far as I understand, is not being used in Egypt. So I hope that this will not be any problem with this drug at all. And if you look into the lopinavir, ritonavir, all the anti-HIV or protease inhibitors coming from the cytochrome effect. So any drug-drug interaction will be coming from the cytochrome effect. And we don't have any clinical trial on this lopinavir, ritonavir for the immunosuppression or for the kidney transplant population. As far as I remember, there is around 1,000 clinical trial ongoing now for COVID, none of them on the kidney transplant population. So I don't think that this would be an issue, hopefully, in Egypt or even outside Egypt.
If you allow me, I want to add just one sentence about the hydroxychloroquine. There is a nice randomized controlled study, which is open label randomized controlled study that was published in British Medical Journal, showed no efficacy of this drug. So it is not only observational, but it seems that the evidence came from some randomized controlled trial, and are waiting the results of the rest of studies. So I think it is very nice. I want to add only 2 points here. Because in some countries who resumed transplantation, they think that the best patient, either living or cadaveric, is the patient with low immunological risk. Patients who, for their treatment, we didn't need either rituximab, alemtuzumab, Campus, or thymoglobulin, or if ATG or thymoglobulin is given, to be given in a very low dose, because these drugs are associated with profound lymphopenia. So it seems that COVID-19 affects the use of immunosuppressive drugs in transplantation and in management of glomerulonephritis as well. So let us go to the rest of the presentation, because we have many data to be presented. The use of anti-infective agents and the immune suppression guidelines from the American Society of Transplantation. And this is a very nice issue of the Clinical Transplantation Journal last year, showing a lot of interaction. I'm going to address this interaction one by one, because they are very practical, and I wanted to address the most important point. So start with antibacterial, the use of erythromycin. Erythromycin is antimicrobial antibiotic that is associated with significant cytochrome BA4 inhibition. And this is important inhibitor for cytochrome system. This is why there is marked interaction. 3+ means marked interaction with cyclosporin, tacrolimus, sirolimus, and everolimus. And the guidelines recommended, if we are going to use erythromycin with these drugs, we should start with reduction immune suppression to 1/2 of the initial dose and to monitor drug level. And for my mind, because there are some transplant physicians who are using erythromycin for the sake of reducing the cost of immunosuppressive drugs, I recommend totally against erythromycin use. Why? Because erythromycin is not a safe drug. It's associated with many side effects, including gastrointestinal tracts and others. So please don't use erythromycin to reduce the cost of medication based on these interactions. Another drug is clarithromycin. Again, it is inhibitor to cytochrome system with significant interactions with calcineurin inhibitors and with mTOR inhibitors, and moderate interactions with methylprednisolone, inhibiting their metabolism, increasing their effect and level. This is why it is better to avoid this combination or to reduce immune suppressive into 1/2. And as you see, this is the grade of recommendation, strong based on moderate evidence. Clarithromycin is present in the Helicobacter pylori eradication. So please be careful about the issue of Helicobacter pylori. And it's better to stop looking at the serology level for Helicobacter and trying to eradicate without symptoms. And it's better to collaborate with gastrointestinal specialists and to put in mind the clarithromycin interactions. If we need clarithromycin, we may shift clarithromycin into azithromycin, because by this shift, we can take the same pharmacological action, but here the interaction is insignificant. So the azithromycin may be a good substitute for clarithromycin. These drugs, erythromycin and the clarithromycins, were enzyme inhibitor. What about rifampicin? Rifampicin is a very important drug for treatment of tuberculosis, but it is associated with significant interactions, not only with immune suppressive drugs, but as well with antihypertensive treatment, with anti-dyslipidemic treatment, and many drugs. So please don't prescribe rifampicin for treating tuberculosis except after reviewing all medications. So here with tacrolimus or cyclosporin or immunotherapic inhibitors, if we use rifampicin, we double the dose of immune suppressive drugs because rifampicin is enzyme inducer. And then we follow up the levels more frequent because we may need to increase the dose of immune suppressive drugs. And I'd like to tell you a clinical story of one of our patients. When we started anti-tuberculosis drug regimen based on rifampicin, and the patient was treated with tacrolimus, we doubled the dose of tacrolimus, and then assessing the level frequently. At the end of the day, we increased the level of the dose of tacrolimus 10-fold. The patient was treated initially before rifampicin by immediate release tacrolimus 2 milligrams twice per day. After adding rifampicin, we reached 20 milligrams twice daily. So 10-fold increase in the dose of tacrolimus to reach this therapeutic level. It affects as well MMF and the mycophenolate sodium, but this is mild interaction. And what is neglected is the interaction of rifampicin with prednisone, because we know interaction with calcineurin inhibitor. But in the past, we didn't increase the dose of prednisone when we start rifampicin. And this explains chronic allograft dysfunction and chronic rejection associated with this combination. So we should be careful increasing calcineurin inhibitors and increasing the dose of steroid, because this drug is increase the metabolism of all these drugs. Rifabutin and rifampicin, maybe they are associated with moderate interaction with immune suppressant, so they are a little bit lower in the interaction than rifampicin, but they are enzyme inducers, need to be put in mind. And as you see, all these are strong recommendation based on satisfactory evidence. These are antibiotics, aminoglycosides, which are associated with nephrotoxicity. If we use them with calcineurin inhibitors, the severity of interaction is significant, 3+, but here it is not pharmacokinetic, it is pharmacodynamic interaction, increasing the side effects on the kidney. So avoid or monitor the drug levels, both immune suppressive and aminoglycosides. For quinolones, ciprofloxacin, ofloxacin, and others, there is moderate interactions with immune suppression. And again, it is pharmacodynamic, increasing QTC prolongation. So monitor this and put it in mind. Ciprofloxacin also with MMF may interfere with the efficacy of MMF. And there is an interesting pharmacodynamic interaction of ciprofloxacin with cyclosporin. There is, if you say there is inhibition of metabolism, I can agree about this point, but at the end of the day, the action of cyclosporin is inhibited on pharmacodynamic. So we should be careful about using quinolones for treating patients maintained on immune suppressive drugs. Chloramphenicol, I think its use is very limited nowadays. The interaction is moderate, and it is enzyme inhibitor. Tigacycline, we have tigacycline here, Tigacyl, which is restricted for sepsis due to Acinetobacter infection. And as you see here, it may be associated cyclosporin may be associated with increasing tigacycline level. And if you go to the literature, you'll find interaction with tacrolimus. So tigacycline may increase tacrolimus level. Here, linezolid is associated with myelosuppression. It's pharmacodynamic if it is combined with antiproliferative and the mTOR inhibitors. Sulfamethoxazole trimesoprim, myelosuppression with antiproliferative. So what we should do is to monitor CBC when we treat these patients. I mentioned that ciprofloxacin reduces the efficacy of mycophenolic acid drugs. The question is why? This is the pathway of the drug. When we ingest mycophenolate mofetil, it's absorbed, and this will release mycophenolic acid into the blood. So this is the first peak, and then it finds its way to the hepatic tissues, where it is glucuronidation occurs, and then it is released again, mycophenolic acid released from the liver to the intestine. So it is enterohepatic recirculation that is followed by another peak. So the active drug of CellCept, mycophenolate mofetil, and mycophenolate sodium myfortic is mycophenolic acid. The total effect of mycophenolic acid producing drug is dependent upon the first peak and the second peak. And second peak, which is dependent on enterohepatic recirculation, constitutes 40% of all of the drug exposure. So if we interrupt enterohepatic recirculation, and here this is the antibiotics, can interrupt enterohepatic recirculation. And I want to nominate two drugs, ciprofloxacin, and the second drug is metronidazole. So both ciprofloxacin and metronidazole may be associated with reduction of the enterohepatic recirculation. This is to be put in mind in treating the patients. Another drug that inhibits enterohepatic recirculation is cyclosporin, and this is very applied. If you combine the mycophenolic acid producers, either mycophenolate mofetil or mycophenolate sodium with cyclosporin, please use the standard dose, which is 2 gram mycophenolate mofetil and 1/440 mycophenolate sodium. But with tacrolimus, there is no interference. Tacrolimus doesn't interfere with enterohepatic recirculation. So this is why in low immunological risk, even we reduce the dose of mycophenolic acid to 1 gram mmF and the equivalent mycophenolate sodium. For antifungal, ketoconazole is a strong enzyme inhibitor for the metabolism of cyclosporin, tacrolimus, sirolimus, and everolimus. So we should be careful when we use this drug. Here from the American Society of Transplantation, it is strong interaction, and they recommend to avoid or to reduce immune suppressive by 50% and to follow level by heart. I want to share with you our experience at Urology and Nephrology Center with the use of ketoconazole, because this was a very smart idea of Professor Sobh since a long time with cyclosporin. And this is the ketoconazole tacrolimus co-administration. This is a randomized controlled study. Each arm included 35 patients, ketoconazole group and the control group. And we succeeded in this study to reduce the dose by more than 50% and the cost of tacrolimus by more than 50%. The more experience was witnessed with cyclosporin. And we have publication up to 10 years follow-up of cyclosporin in randomized controlled study. 50 patients in each arm, and in this study, more than 50% of the dose was saved. I want to add a few points here. When we use ketoconazole, we use it in modest dose, 100 milligram, with very small dose of immune suppressive guided by the level. So at least 50% reduction of cyclosporin. By using ketoconazole, we reduce the metabolism, we reduce metabolites, and we keep the mother drug. Ketoconazole may be also associated with immune modulation and antifungal effect. This is why in this randomized controlled trial, followed up for more than 10 years, it was successful to use ketoconazole with cyclosporin and with tacrolimus for 2 years follow-up. In nephrotic syndrome, ketoconazole was shown to be independent associated with good response and remission of nephrotic syndrome. Unfortunately, this drug is not available nowadays in Egypt, and it's prohibited to be used. Another drug. Here, I'm not going to read all these drugs, but I want to address acyclovir. When we give acyclovir with immune suppressive drug, we should be careful about tubular secretion and the kidney function. And if a cyclovir is given with cyclosporin or tacrolimus, this is a significant interaction that may be associated with nephrotoxicity because of pharmacodynamic effect. So please, if this drug is given, should be given in a hydrated patient, and the kidney function is monitored well. For hepatitis C, again, we don't like ritonavir drug, which is used here in Curivo. This regimen increases cyclosporin by 5 to 8-fold and increases tacrolimus 57-fold. This is why if Curivo is given with cyclosporin, use 1/5 of the dose of cyclosporin. And here it's better to avoid combination of Curivo with tacrolimus. We have an experience with using Curivo with tacrolimus. We used to have milligram once per week or once every 2 weeks. And then we adjust rough level after 1 week of tacrolimus. So we don't like this combination nowadays, and we stop the use of Curivo with tacrolimus. Another drug, which is elbasvir grazoprevir, known as Zibater, which can be used in any stage of kidney function, even in dialysis. But this combination should be avoided with cyclosporin, because cyclosporin increased grazoprevir 15-fold rise. This is why, this is a very simple manner. This is a heat map. These are the direct anti-hepatitis C drugs, and these are the immune suppressive medications. Whenever you find a green land, this means that interactions, there is no significant interaction, and we can use this combination. If you find yellow color, this means to be careful. But red zones means combination should be avoided. So Zibater with cyclosporin to be avoided. The Curivo with either tacrolimus or sirolimus or everolimus to be avoided because of drastic enzyme inhibition and toxic, and this will be toxic. And here we have other drugs that can be used instead of these red color drug combination. So if you find the red color, this means the combination is prohibited in treating hepatitis C. Let us go to one of the interesting points. If we are dealing with HCV positive recipient, is there any tendency to use certain immunosuppressive drugs? This is the Kiduki commentary in KDIGO that was released this year. They're suggesting that all conventional current induction and the maintenance immunosuppressive regimens can be used in HCV infected kidney transplant recipients. I want to add, if we treat hepatitis C after kidney transplantation by direct antiviral drugs, we should pay attention to drug-drug interaction. And moreover, even after discontinuation of direct antiviral drug, we should keep monitoring drug immune suppressive level frequently. Why? Because after clearing hepatitis C by direct antiviral drug, metabolism of drugs is enhanced. This is why we should be careful when we use the drugs and after discontinuation of the drugs. This is the nice and the very interesting. This is an HIV patient. The patient was transplanted and then experienced graft failure and was maintained on small dose tacrolimus. And then the dose of this drug, which is anti-HIV, is increased. What happened? Tacrolimus level reached 60 nanogram per ml. That was associated with encephalopathy. Despite discontinuation of anti-HIV and tacrolimus, still tacrolimus is maintaining a high level and encephalopathy doesn't improve. So what the author did here, they used phenytoin as enzyme inducer. So phenytoin is used here to enhance the metabolism of tacrolimus. And after taking the phenytoin, what happened? The metabolism is enhanced and the cerebral, the encephalopathy resolved after clarification of tacrolimus level. Why I mentioned this case? I mentioned this case not to use the drug to enhance the metabolism, but to put in mind when we have transplanted patient who is treated with tacrolimus, and the patient has convulsion, and you decided to give him phenytoin. You should be careful because phenytoin is significantly associated with enzyme induction. I remind a case that we have since more than 20 years. The patient was transplanted and suffered from severe pneumonia and was ventilated. And then we stopped all immune suppressive drugs, calcium inhibitors, and antiproliferatives. And Professor Sobh at that time make a very smart idea. Why not to give this patient rifampicin to enhance the metabolism of the drug? It seems that we may use drug-drug interactions by way or another. So I like also to hear from you if you have any comment, Dr. Kossi and Dr. Halawa.
Just let me get this right.
Yes.
Thank you, Professor Hussein. Actually, two things. Just we have to remember that using trimethoprim is associated with increasing creatinine, but is not due to toxicity. Is because it inhibits secretion of creatinine through the proximal convoluted tubules. So there is no drug-to-drug interaction on the kidney, but of course on the white cell count and the bone marrow. The second thing regarding your study, which using fluconazole in reducing the dose of tacrolimus and subsequently reducing the cost, you're not worried about drug resistance because fluconazole is a valuable antifungal treatment, and the transplant patient will get some fungal treatment during their life. So you're not worried about drug resistance?
We have 10-year follow-up, and the one of the advantages is the infections after using this drug was insignificant. There was no fungal infection in the patients treated, so this is another advantage of the use. We use modest dose and continued for forever with the immune suppression. And we got the message from hepatologists. Fluconazole is hepatotoxic. So our reply was, cyclosporin is hepatotoxic as well. So if we combine mild dose of fluconazole and reduce cyclosporin and reduce metabolites significantly, the sum effect of using this combination may be even less hepatotoxic than they saw.
Another thing, actually, Professor Hussein, we need to welcome Dr. May Hasaballah and Dr. Faisal Shaheen and Dr. Dawlat. All of them are with us today.
Thank you for this point, because I like this point because I need Professor Faisal Shaheen, because after a minute he will find some referral to his presentation of post-transplant diabetes. I welcome the return of Professor Dawlat and Professor May with us. Always, it is an honor and a pleasure to have them with us. They are my professors. Dr. Kossi, do you have any comment to add?
Oh, thank you very much. It's very, very excellent, to be honest. Only one little comment about the HIV patients. We usually, probably this is the same practice everywhere, a trial for the anti-HIV medication, particularly the protease inhibitors with the tacrolimus, to reach the appropriate dose before we transplant the patients because of the severe drug-drug interaction. So we usually just use both of them as a combination prior to transplant the patients. Once we have reached the appropriate dosage, then we go ahead with the transplantation. Yes. This is just a little comment.
I want to clarify a point here, because we don't have an experience of HIV and transplantation. No transplantation for AIDS. If the patient has HIV complicated by AIDS complex, this is a contraindication for transplantation. But if HIV infection is controlled by antiretroviral drugs with everything is controlled, there is a big series transplanted in different countries. Okay, let us go to the metabolic disorders, and this is a funny part of the presentation and interesting as well. I would like to thank and appreciate Professor Hussein Sheashaa for delivering this very nice presentation, very comprehensive about the post-transplant diabetes. And when I say metabolic abnormalities after transplantation, hyperglycemia is one of the most important metabolic disorders, and dyslipidemia. I'm not going to discuss post-transplant diabetes, but Professor Hussein Sheashaa mentioned the how to treat, how to diagnose, and how to manage post-transplant diabetes. I'm going to concentrate on 2 points. If we treat diabetes after kidney transplantation, we should focus on kidney function. Because as Professor Sheashaa stressed, if estimate GFR is less than 30, we cannot use metformin and as well sodium glucose transporter inhibitor. It is clear from his presentation. But what I want to add today, when we have a case and want to give antibiotic drugs, there is some drug interaction with antibiotic drugs with immune suppressive drugs. For example, if you look at the ribaglenide, where is ribaglenide? This is ribaglenide. If it is combined with cyclosporin, cyclosporin inhibits the metabolism of ribaglenide. So ribaglenide, it's better to be avoided with cyclosporin because cyclosporin will inhibit the metabolism of this drug that can lead to hypoglycemia. And I'd like to share with you this is a very smart table created by the clinical pharmacy department at our center. This is a very simple. Don't combine cyclosporin with ribaglenide because of the risk of hypoglycemia. And if it is the treatment, we should be very cautious and monitor a glycemic control. Myself, I don't recommend at all combination of these drugs. Rosiglitazone with MMF rosiglitazone increase my MMF toxicity. Sitagliptin, glipizide, and glyburide may increase cyclosporin toxicity. So if we treat a patient by antibiotic drugs, so to review the medications, to know which drug is to be modified, which drug to be chosen and selected. Don't forget kidney function and don't forget drug-drug interaction. The most important part in this presentation is drugs and dyslipidemia. I think it is a very busy slide, a very difficult slide, but I'm going to explain it bit by bit. So for lipids, we have 2 sources of lipids. Exogenous from food, and exogenous lipids constitute 30% of the calories. So from food, we intake triglycerides, mainly triglycerides. So through the exogenous pathway, we have triglycerides. From endogenous pathway, from hepatic, we have cholesterol synthesis through HMG-CoA reductase. So we have exogenous and endogenous pathway. Triglyceride is taken by chylomicron, and the triglyceride by hepatic lipase and the lipoprotein lipase, we will have chylomicron remnants and very low density lipoprotein that is metabolized to intermediate density lipoprotein, and by lipoprotein hepatic lipase, intermediate density lipoprotein is changed into low density lipoprotein that is taken by hepatocyte and other cells. HDL is important. Why HDL is important? By the presence of HDL and the LCAT enzyme, cholesterol is taken by liver cells. So this is a reverted pathway. Cholesterol is taken from tissues to the liver. So by this structure, we have exogenous, endogenous, we have cholesterol synthesis, and we have hepatic metabolism, and we have lipoprotein lipase activity, we have cholesterol intake by liver. This is homeostasis. If homeostasis is disturbed, what happens? LDL exceeds and is taken by macrophage to form foam cell with subsequent atherosclerosis. So this is just to show lipids in a very quick manner. What is the effect of immune suppressive drugs? Regarding steroid and the calcium inhibitors, they may be associated with insulin resistance. And the insulin resistance inhibits hepatic lipase and inhibit lipoprotein lipase, so and inhibit LDL receptor. So steroid calcineurin inhibitors are associated with inhibition of LDL receptor. We need LDL receptor to get rid of LDL. So if LDL receptor is inhibited, lipase is inhibited, and PCSK9, this is another structure, when it is exaggerated here, steroid and cyclosporin stimulate PCSK9, which inhibit LDL receptor again. Inhibition of LDL receptor increase LDL. So the use of steroid calcineurin inhibitors are followed by these mechanisms that leads to disturbance and dyslipidemia, increasing LDL. The main mechanism linking mTOR inhibitors, sirolimus and everolimus, with hypercholesterolemia is through stimulation of PCSK9. This is the main mechanism. PCSK9 is a very important part of the receptor. When it's exaggerated, LDL receptor is inhibited. This is why nowadays there is drugs that work to inhibit PCSK9 monoclonal antibody given for familial hypercholesterolemia. So this is the mechanisms how immune suppressive drugs drastically affect the lipid. Let us go organ by organ. How immune suppression affects organ. It affects intestinal absorption through affecting the transporters, affecting hepatic, reducing lipoprotein clearance. Corticosteroid and calcineurin inhibitors disrupt hepatic function for clearance of lipids. Inhibits the pancreas islets, so it will inhibit insulin secretion by calcineurin inhibitor and mTOR inhibitors. Again, lipolysis by corticosteroid and mTOR inhibitors. Vascular, here reduced lipoprotein clearance from endothelial side by corticosteroid, calcineurin inhibitor and mTOR inhibitors. Muscles, reduced intake. So the use of immune suppressive drugs are affecting all organs that can share of lipid homeostasis, leading to derangement of lipids. So I'm not astonished if we find this table. Corticosteroid are associated with increased total cholesterol, LDL cholesterol, triglycerides, and a modest increase of HDL. But I think the effects on total cholesterol, LDL, and triglycerides outweigh any beneficial effect of HDL. Calcineurin inhibitors, cyclosporin is associated again with all these derangements. I want just to share with you the difference between cyclosporin and tacrolimus in LDL cholesterol. Cyclosporin is associated with more increase of LDL. Why? Because cyclosporin enters the cell through binding LDL receptor. So there is competition between cholesterol and the cyclosporin to enter the cell. This is why in treating nephrotic syndrome with hypercholesterolemia, we need in the starting of treatment higher dose of cyclosporin. So there is cyclosporin is associated with increased LDL. Rapamycin and everolimus, sirolimus and everolimus are associated with hypercholesterolemia, and as I mentioned in the previous slide, through stimulation, mainly through stimulation, PCSK9, which inhibits LDL receptor functions. Is there any effect of antipurine, either azathioprine or mycophenolate? Their effects on lipid is neutral. So this slide, this table summarizes the effects of immune suppressive drugs on the lipid profile. I would like to show you this heat map, very nice table, shows the interactions between different immune suppressive drugs, cyclosporin, tacrolimus, sirolimus, everolimus, steroid, MMF, and azathioprine. And these are the drugs that treat dyslipidemia. All of us are aware by statins, atorvastatin, fluvastatin, pravastatin, rosuvastatin, simvastatin, all these are statins that inhibit HMG-CoA reductase, reducing cholesterol synthesis in liver. And then we have ezetimibe or ezetimibe, which inhibits intestinal absorption of lipids. Fibrates, which attacks triglycerides. Bile acid sequestrants, niacin, omega-3 fatty acids, and these mepo, mersen, and the lumetabide are investigational drugs targeting lipoprotein. And then PCSK9 inhibitors, either alirocumab or evolocumab. These are the drugs, immune suppressive drugs and anti-dyslipidemic drugs. What are the interactions? Look at the color. If the color is deep, don't combine. Deep red color or brown color, this is, I don't know if it is deep red or brown, but the darker color in this slide means it is contraindicated to combine cyclosporin with lovastatin. To combine cyclosporin with simvastatin, it is contraindicated. It is contraindicated to combine cyclosporin with fibrates. So deep color means contraindication. The lighter one, this means major interaction. The yellow color means mild interaction. And the green color means no problems. So there is no problem to use all these drugs with steroid, MMF, or azathioprine. But again, bile acid sequestrants are not welcomed at all with steroid, MMF, and to be very cautious when the bile acid sequestrants are used with these drugs. By the way, the only drug that can be given during pregnancy for lipid is bile acid sequestrant, but we should use it away completely from immune suppressive drug, as you see here, and it is contraindicated to be given with steroid and mycophenolate mofetil. The PCSK9 green all through. This means that this class of drugs is still we need an evidence for using them in transplantation. But I think if we have severe dyslipidemia, I think they can help for treating dyslipidemia and hypercholesterolemia in these cases. So this is a very nice table, shows the interactions. Let us go to the dosages. If we use atorvastatin, why we are afraid of combination? Because if this anti-dyslipidemic drug increase cyclosporin, I can reduce cyclosporin. The problem is cyclosporin inhibits metabolism of statin or interrupts transporters for those who are not metabolized by cytochrome system. This means that cyclosporin will increase level of statin that may be associated with rhabdomyolysis. This is why with atorvastatin, the maximum dose of cyclosporin is 10 milligram, not 80 milligram. In normal daily life, the maximum dose is 80 milligram to treat atherosclerotic coronary heart disease in diabetic patients. But if cyclosporin is there, the maximum atorvastatin is 10 milligram. Lovastatin to be avoided. Simvastatin maximum 10 milligram with cyclosporin, and this is the maximum 20 milligram fluvastatin. Rosuvastatin 5 milligram. You can ask me why. Rosuvastatin is not metabolized by cytochrome system, but its transportation by protein is inhibited by rosuvastatin. So it is very wise to follow this interaction. Ezetimibe, to be cautious with cyclosporin because it may be increased up to 12-fold. And the combination of ezetimibe with other drugs, it should be more and more careful. In children, these are the dosages in the children. And I'm not going to read this table, but during the video, you can fix this table and it shows the daily dose in children and how to handle these dosages in the presence of renal impairment and with other drugs. One of the most important side effects of dyslipidemia, of immune suppressive drug, is hyperlipidemia, especially in mTOR inhibitors. And this table shows if we have mild increase in LDL, we can reduce the level of mTOR inhibitors and we use anti-dyslipidemic drugs. And if there is increased triglyceride, we can use fibrates. But if there is very high level both cholesterol and LDL, we may think of shifting the drugs. But I have a question here. mTOR inhibitors, sirolimus and everolimus, are associated with hyperlipidemia and hypercholesterolemia. Does this mean that these drugs are atherosclerotic, increase atherosclerosis? The answer is no. Why? This is sirolimus paradox or mTOR inhibitor paradox. Although they increase cholesterol, but they stabilize atheroma and inhibit inflammation and macrophage because they are anti-proliferative. So they have anti-atherosclerotic. And as you know, we have eluted stents by different members of mTOR inhibitors. I prefer also to stop here for a while to have any comments from my professors and from the audience. Dr. Kossi.
Thank you very much. It's very nice and interesting presentation, to be honest. I can't add anything.
Dr. Ahmed?
Yes, actually, our protocol, actually, we use atorvastatin with the transplant patient rather than simvastatin.
Okay.
And the main worry of simvastatin is a muscle damage, muscle necrosis, or muscle pain.
Yes.
Yeah. And this is why we think, I mean, atorvastatin is not 100% safe as well. You know, it's still, you know, a toxic drug and can cause the same damage. And we stopped the medications, you know, the anti-lipidemic medications when the patients, you know, have symptoms or the creatine phosphokinase is high. And we revert to another, azintemib, as another drug if there is side effects with atorvastatin. It's quite tricky, and I strongly agree with you regarding mTOR inhibitor and its anti-atherosclerotic effect. And actually, we in cardiac they use a treated stent, basically is mTOR-coated stent to increase the longevity of the or the patency of the stent, and the same for vascular as well. And thank you, Professor Sheashaa. It's quite a very informative part of the lecture.
Dr. Dawlat?
I totally agree with Professor Halawa. The stents which are loaded with rapamycin, I'm quite acquainted with this.
Dr. May?
Hello, everybody. Nice to see you all. Hussein, you're tackling one of the very difficult subjects, drug-drug interactions. And I'm really glad to hear that, because these things are not always at the tips of your fingers. So you need to hear about it, and you have to really think hard before you prescribe anything with immunosuppression. So I think this is a very important lecture, and thank you very much for it.
Thank you. Dr. Faisal?
Yes, I thank you, Prof. It is excellent talk, actually. I'm so happy to hear. I learned a lot from you today, actually. And this is an important subject because many doctors, non-professional, they prescribe any medications for the patient who will be in post-transplant, especially statin, which can interact and can cause a lot. And I have a couple of patients came to me with myopathy, and they cannot walk. And the problem was mainly due to introducing statin by one who is not nephrologist. So I think you tackle the subject very well, and the comment of Dr. Halawa, I agree 100%. Thank you very much.
Thank you very much, Professor Faisal. And I'm going rapidly. I still have 15 minutes to stop. 15, not 50, 15, 1-5.
Good.
So let us go very rapid to some interesting points. If we have a patient who is transplanted, this is a case of kidney and pancreas transplantation. The patient is maintained on triple immunosuppressive therapy, prednisolone, tacrolimus, and the microbiome. And then the patient presents with chronic diarrhea. If we have chronic diarrhea, and I would like to appreciate the efforts done by Professor Halawa in the Journal of Egyptian Society of Nephrology and Transplantation. He wrote a very clever and very smart algorithm how to deal with diarrhea. But principally, we shouldn't jump to immune suppressive drug because all of us jump to reduce immune suppressive drug. We should put in mind the clinical presentation. And we have infections, and the type of infection is different from country to country. So in Egypt, for every case of chronic diarrhea, we should request CMV, PCR after transplantation. And when we think of others, in other countries, you will find other viruses, funguses. And I remember one of the very interesting cases presented by Professor Al-Ghamdi when he presented a mysterious case of chronic diarrhea, and the diagnosis was established only after doing colonoscopy and the biopsy, and the organism was attached to the colonic mucosa. So this is why we need to know, to have an algorithm for management of chronic diarrhea. Malignancy to be, I think it is easy to exclude malignancy by plain X-ray, ultrasound, checking the carcinoembryonic antigen, BSA, all these are well known, the clinical manifestation of the patient, and metabolic profile. If all these, we are confident that there is no infection, no malignancy, then we are in the territory of drugs. The use of mycophenolic acid is famous by diarrhea. And here is tricky. I'm not convinced that there is a difference between mycophenolate mofetil and the mycophenolate sodium recurrent diarrhea, because at the end of the day, they are producers of mycophenolic acid. And diarrhea is because of the side effect of mycophenolic acid on the small intestine, because it may lead to atrophy of the mucosa of the intestine. And some countries know well the pathology of mycophenolic acid related intestinal derangement. But anyhow, everything in this case is excluded. So the question, if the infection and malignancy is excluded in this case of kidney and pancreas transplantation, the MCQ here is to start lopramide, to lower mycophenolate dose, discontinue mycophenolate and maintain on tacrolimus and prednisone, to switching mycophenolate to other cerebrine. I forget to tell you that they reduced the mycophenolate to 1 gram. So the next step is to do more reduction or to give the patient any of the other choice. The answer is we shouldn't start lopramide for infective diarrhea or for this diarrhea. Lowering the mycophenolate dose below 1 gram or mycophenolate sodium below 720 is a risky business that may be associated with rejection. So if we reduce the frequency, if we increase the frequency, so instead of giving the drug in twice a day, 4 times a day, divide the dose in 4 doses, or decreasing the dose down to, with tacrolimus down to 1 gram, below 1 gram it is risky. So we prefer to shift to other cerebrine. So if we reduce a MMF to 1 gram, the next step is to shift to other cerebrine. Before leaving this part of presentation, I would like to comment about diarrhea associated with tacrolimus, because tacrolimus may be associated with diarrhea, and diarrhea is associated with increasing tacrolimus level. We expected that diarrhea will lead to increased transit time, so the drug is, we get rid of the drug through diarrhea, so are expecting lower level. What happens? Higher level. Why? Why it is contradictory? Because in diarrhea, there is abnormality in the intestine. And one of important part of the intestine is the drug efflux pump. And the drug efflux pump pumps drug, tacrolimus, from the intestinal cell to the lumen. So if the intestinal cell is drained, this efflux is inhibited. And another more simpler is intestine shares in the metabolism of tacrolimus. Cytochrome B system is available in liver and in the small intestine. So in the diarrhea and the intestine is affected, drained, metabolism of tacrolimus is affected. This is why in tacrolimus we have, in the diarrhea we have higher level of tacrolimus. Very rapidly for reproductive health, this is the algorithm. And if we are thinking of the lady, you will find here, this is the red line. Pregnancy in the first year is prohibited at all. And in the second year, it is yellow color, is to be cautious, because the safest time to allow pregnancy is after 2 years of transplantation. The minimum is 1 year. How to handle immune suppressive drugs? MMF or mycophenolate sodium mycophenolic acid producers are associated with teratogenicity. This is why we should stop them, replacing them by azathioprine 6 weeks in advance before stopping contraceptive methods. And after delivery, in lactation can be allowed while the lady is on prednisolone, calcineurin inhibitor, azathioprine. There is no data about mycophenolate or mTOR inhibitors. So this is why if the patient is maintained on mycophenolate or mTOR inhibitor, breastfeeding is not encouraged. For males, we put in mind that mTOR inhibitor may be associated with hypogonadism and may affect spermatogenesis. And there is theoretical hypothesis raised by European medical agency since a couple of years that if the father or the man is receiving mycophenolate, then he should practice sex with a condom. And then to replace mycophenolate to azathioprine 90 days and continue condom for 90 days before allowing him to be a father or to commit sex without this condom. I think it is theoretical and there is no agreement about this point. And the British Renal Association recommends or suggests to sit with the patient and discuss this theoretical teratogenicity. Here, I'm not going to read this table. Corticosteroid can be given so long as it is small dose because placenta metabolized prednisolone by this enzyme 11-beta hydroxysteroid dehydrogenase. Calcineurin inhibitors can be given safely during pregnancy without problems or significant problems, although we need to monitor the drug well. Mycophenolic acid is teratogenic, so it is completely contraindicated. Azathioprine, this is the tricky here. Azathioprine, maternal and fetal exposure appear to be similar. Why we allow azathioprine? Because the toxic part of azathioprine is 6-mercaptopurine. Azathioprine is prodrug. Fetal liver, the liver of the fetus, is unable to change azathioprine to 6-mercaptopurine. So this is why it is safe to be used during pregnancy and lactation. What about contraceptive methods? This is the recommendation of Center of Disease Control. Here, if we are reacting with normal graft function and complicated graft, we can use any type of contraceptive method by the lady preference and her doctor preference. And there was an old dogma that immune suppressive drugs reduce the inflammation exerted by IUD. There was afraid that the use of contraceptive reduced the competency and the efficacy of IUDs. It was not proven. If we have complicated grafts function, here this is the combined estrogen containing pills, it is contraindicated because this is an acceptable risk. 3 means risk outweighs benefits. So if we have graft dysfunction, it is better to use any of these that carries the two, either dermaplant or progestin only pills. So and avoid IUDs and combined hormonal contraceptive pills. The tendency nowadays is to encourage lady for lactation, provided that she is treated with steroid, calcium inhibitor, and azathioprine. And as you see, the trend for allowing lactation is increased up to 80%. In our experience, we were against lactation, and we give the lady drugs to inhibit lactation, but we think to review our trend for the psychology of the patient, so long as the lady is maintained on steroid, calcium inhibitors, and azathioprine. Do you like to comment here, their professors? you have any comment, Dr. Ahmed?
I mean, actually, no comment, but just you know, to stress on the point is with diarrhea, as you mentioned, the CNI level will be high.
Yes.
Because actually, I would like to make it simpler to my colleagues, because the bowel is an excretory organ for CNI. So, and with diarrhea, the P protein is inhibited. So subsequently, the excretion of CNI through the small bowel is reduced. And this is why you have high level. There is a misconcept that, you know, diarrhea and the, you know, associated with low level of CNI because of the interruption of the enterohepatic circulation. No, this is not true. It's actually is high. And yes, this is an important point, and thank you for addressing this point. Also, in terms of lactation, yes, I agree. We should encourage lactation and a normal breastfeeding because actually they checked actually the drug levels in the fetus. There is minimal, very minimal, very small to affect the fetal growth. And I wish that you could have mentioned as well, you know, if you discuss pregnancy and the other drugs which is contraindicated, you know, before getting pregnant for transplant patients, like the, you know, they are not immunosuppressive drugs, like, you know, angiotensin receptor inhibitors and the other, you know, antihypertensive, which shouldn't be given during before pregnancy, should be switched off before pregnancy.
Regarding ACE inhibitor and ARBs, they are completely contraindicated beyond the first trimester. This is why if we have a lady who come to us pregnant in the first trimester while she is receiving ACE inhibitors or ARBs, we just stop them because they will not lead to the catastrophic kidney agenesis or lung agenesis except beyond the first trimester. This is why there are, in the general nephrology, there are two schools. Either to stop ACE inhibitor or ARBs in the childbearing period altogether, so long as the lady wishes to be pregnant and who are not sure when she will be pregnant, or if the lady is educated enough and we need to give her antiprotonuric drug, and we should educate her about the amenorrhea, if she has amenorrhea, to test for pregnancy and then to stop the ACE inhibitor, because ACE inhibitor and ARBs are absolutely contraindicated after the first trimester. But as you mentioned, we should put in mind, as well as statin and other drugs, statins is contraindicated in pregnancy. This is why we should review all medications, not only the immune suppressive drugs. Professor Dawlat?
Yes, I just have a comment about the azathioprine. We know that during pregnancy, the fetus doesn't have the enzyme in its liver to activate the azathioprine, but as soon as it is delivered, the child develops this enzyme, and therefore azathioprine would be toxic as it is excreted in the milk. So I think that it's used with lactation.
But its level in the milk, I think it is very low level.
Very low level.
Very low level that doesn't, so there is a risk benefit. At the end of the day, for the psychology of the lady and for the remote possibility of the side effects, nowadays the trend all over the world is to allow lactation. Dr. Faisal? Dr. Faisal, unmute.
Okay.
Yes, please.
Thank you very much. I wonder why some patients develop diarrhea on and off. Let us say just a case scenario that some patients who have diarrhea, you manipulate with MMF drug, either you make it 3 times or you reduce the dose, then the diarrhea stop and for some time and then return back again with the same problem, and you have to tackle the thing. Why this happen? Can you explain this? This is the first.
It is quite a problem, but we witness this problem in some of our patients, may be related to their habits in the nutritional status, because as you know, these patients are immune suppressed and they are not sure of the sanitation of the food. This is why we address and advise them in the early period of transplantation to eat cooked foods to be sure that they are disinfected. So we repeat the investigation every now and then, and it is really problematic for us.
Okay, the
There's
second.
also-
Okay, sorry, Mohsen, go ahead.
Do you
No,
have?
no,
No, it's Ahmed.
There's also alteration of the bowel flora with immunosuppression.
Yes, yes, yes.
So what happens after immunosuppression? Everything's changed. The bowel flora, and which was not different population, populated with different organisms. So the situation is completely different after transplantation.
There are many papers confirming that tacrolimus affects the gut microbiota significantly. And I think the last slide of my presentation is about gut microbiota. The second point, Professor?
Second, about the lactation. We have many published paper about pregnancy and after transplantation. Dr. Sayari, myself, and many of our colleagues report maybe the highest number of pregnancy post-transplantation. We didn't, stop iron lactation. We encourage the mothers for lactations, and I think the children usually doesn't have any problem in all our series of which we published. Just for the information.
Thank you very much. Because after reading the literature, we start nowadays to change our mind. Because it was a dogma in our practice, is to give Barlodel to stop lactation, and that's it. But so long as the baby is good, delivered well, the immune suppression status is safe to be given, because there is up to this moment no data about mTOR inhibitors and the microfolic acid producer during lactation. So if the lady is maintained on steroid, calcium inhibitor, azathioprine, we can allow lactation. If her immunological risk cannot withstand and we should use microfolic acid producers, I think we will be against lactation in this case.
I'm sorry, my last question, I'm sorry that I took time.
No problem, take your time.
Yes. Did you recommend any probiotic in a patient with diarrhea, frequent diarrhea?
With diarrhea in general, it's completely different than transplant, because I'm not sure if it works well in transplant environment. But there are some studies in general population about the using drugs that handle the gut microbiome, either prebiotic, probiotic, or symbiotic. And the most important is to stop medications, because one of the major drugs that affect the gut microbiota is the use of the proton pump inhibitors. And I think in Saudi, you use frequently proton pump inhibitors with immune suppressive drugs for the sake of the stomach and the gastritis and the symptoms of gastrointestinal.
Yes.
And these drugs are bad for the gut microbiome. And I think other drugs affect. But for my point of view, I can encourage transplant patients to eat fibers, diets rich in fibers after stabilization of the graft function. Because the high fiber diet can, as I'm going to mention at the end of the presentation, can support gut microbiome and even can enrich and flourish T regulatory cells. دكتورة سامية إبراهيم.
أيوة السلام عليكم.
وعليكم السلام. تفضل يا فندم.
Of course, we know that anti-proliferative drugs are already contraindicated, and if we are planning the patient to get pregnant, we are going to prescribe the azathioprine. Okay. So suppose the patient came and discovered that she is pregnant and she is already in the first trimester. Are you going to terminate or
a very nice question that we discussed it many times. I remember that we discussed it with Professor Ahmed Denewar since more than 10 years. And there is no clear-cut answer from the literature. I'm not going to terminate pregnancy because the lady was treated by microfolic acid producers, either MMF or microfolic sodium. What I recommend is to assist the baby by ultrasound, amniotic fluids, and to have the consultation of obstetrician he may request, if he is suspicious, to do amniocentesis to assess alpha-fetoprotein and others. And if there is no congenital anomalies, we just stop MF, and that's it. I'm not sure if Dr. Kossi and Dr. Halawa have another opinion. Dr. Kossi.
Just only a comment about the approach to the diarrhea. As you mentioned clearly, the PPI usually we stop it straight away,
Yes.
particularly if all the investigations come back to be negative for any predisposing factor. We recommended the Yakult, which was one of the probiotics. I'm not sure whether this makes anything or any difference to the chronic diarrhea or not in this population. As regards the mycophenolate, as you mentioned clearly, yes, if it is, the amniocentesis or just the ultrasound scan didn't show any fetal defect, then we carry on and we'll inform the mother what's been happening, but we don't terminate.
Okay, I think we agree about this point. So to go rapid to the rest of the presentation, I just have 5 minutes to stop. The bone pain. This is a case published in the journal since many years, about 9 years of resistant disabling foot pain in kidney transplant recipient treated with cyclosporin, low level, everolimus, and steroid. If we have a transplant patient like this, we should investigate the metabolic profile. Gout will lead to unilateral pain. The patient is not gouty. There is no infection. The MRI was done and it reveals some sort of bone marrow edema. If this is the case, how to treat this patient? The treatment, just to save time, the diagnosis, if there is no infection, no metabolic abnormalities, nothing, we should put in the diagnosis calcineurin inhibitor related bone pain. Because calcineurin inhibitors lead to a vasoconstriction of the bone vessels. And if this is 9-year disabling bone pain, we stop. This is the recommendation to reduce calcineurin inhibitor. Don't forget, this patient was treated with a low dose and low level cyclosporin. Although the level was low, but the patient has pain, so we should stop. So if the pain is mild, we can add dihydropyridine calcium channel blocker, because dihydropyridine calcium channel blocker can lead to vasodilation of the bone vessels and reduce bone pain. If this doesn't help, I think it is better to stop calcium inhibitor. So this is calcineurin inhibitor bone pain. In very azathioprine and allopregnanolone, I think all of us know this point. In the current era of medicine, we shouldn't combine allopregnanolone with azathioprine, because allopregnanolone inhibits metabolism of azathioprine, and this will lead to toxicity. So in the current era, we have mycophenolate, so no way. Is there a difference between allopregnanolone and febuxostat? No difference. Don't combine azathioprine with febuxostat or allopregnanolone. Regarding immunotherapy for cancer, this is I think this is a difficult issue, but I'm going to highlight here interaction by different way. Immunotherapy used for treating cancer work by inhibiting some signals like programmed death 1, because programmed death 1, when it's stimulated by the ligand presented by antigen cell from cancer, this will stimulate programmed death 1 on lymphocyte with subsequent inhibition of lymphocyte and the cancer flourish. Immunotherapy depends upon inhibiting these pathways that lead to stimulation of T lymphocyte to combat malignancy. A stimulation of lymphocyte in transplant patient will lead to rejection. So this is another interaction. So if we are requested in cancer and oncology department, we should know that they may have drugs that are FDA approved for devastating malignancies like melanoma, lung cancer. So if we are in kidney transplant, do we agree to give them immunotherapy for cancer? We calculate cost benefit with oncologist case by case, because even if kidney transplant fail because of rejection and we have devastating malignancies that is treated effectively, this will be a gain for the patient. The patient will take the benefit of getting rid of cancer. But for liver and heart, if liver and heart fail, the patient will die. So it is different from case to case. This is systematic review. As you see here, 64 patients transplanted treated by immunotherapy because of malignancy, and rejection occurs in 40%. And I think there is no time to explain the type of transplantation, all this, the organs and the malignancy. Another big systematic review for 80 cases, 83 cases, showing the same. Use immunotherapy are associated with high risk of rejection and maybe mortality. This is why we should calculate risk in according to the behavior of malignancy, according to the response of malignancy, and with the oncologist to discuss it case by case. This is a very nice. I read this article. It is experimental work. How to manipulate gut microbiota in experimental transplant model in rats, and by using high fiber diets without immune suppressive drugs, high fiber diet, which is rich of prebiotic, is associated with improvement and reduction and the prevention of dysbiosis and abnormality of gut microbiome, and protect against renal allograft rejection. Why? Because the high fiber diet was associated with increased regulatory T cell, as shown by the marker of T regulatory cell in this experimental animal model. And I dream that tolerance may occur, and I think it is impossible nowadays to recommend a high fiber diet instead of immune suppressive drugs, but it is a dream how to target different pathways to have drugs without side effects and keeping the graft functioning at all forever. And I attended this session in ESOT conference since 2019, and this was a very nice session about whose responsibility is it? Is it the transplant physician, surgeon, immunologist, the clinical pharmacist? I think it is our responsibility all to work together for the sake of the success of transplantation. And I think all these presentation and seminar will add to our information. And by knowledge, I think our practice can be changed. Before stopping, I would like to recommend reviewing all medications, because sometimes using medication may lead to catastrophic end. I remember a case, she was on nephrotic syndrome, treated with cyclosporin, and she was hypothyroid, and coming to me complaining of low hemoglobin, and she asked me about what's your opinion, Hussein, about iron sulfate. I told her it's okay, use iron sulfate, no problem. And when I reviewed the MaxApp, I found a case, the patient with hypothyroid came to emergency department with hypothyroid coma. And there was an MSQ question, which drug precipitated myxedema coma? It was iron sulfate, because it interferes with the absorption of thyroxine. So we shouldn't forget, I educate myself and my colleagues that this is my responsibility to prescribe the drug. I should know everything about the drug before prescribing medicine, not to avoid doing harm, because this is the ethics of medicine, is to avoid doing harm. Thank you very much for your attention. And if you have any points to comment before shifting to Dr. Ahmed Denewar. Do you have any points to raise?
Yes. Do you mind? I have just one comment.
Okay.
Is for intractable severe diarrhea not responding to any other measures, provided that is not infective in origin, there is an option of fecal transplantation.
Yes, it is still investigational, and
absolutely.
And I think it is proven on the randomized controlled trial for devastating inflammatory bowel disease and other causes. But still in transplantation nephrology, we are wondering. But I think the route of administration of fecal transplantation is improved since a long time. But still when you hear fecal transplantation,
smells.
Yeah. You become.
It's not a nice feeling.
Yeah.
Yeah.
Is there any point to be discussed? Dr. Tariq Antawi, do you want to add anything? دكتور طارق حبيبي.
Thank you, Dr. Hussein. Was a nice presentation. Thank you.
I think the drug is our responsibility. We should be cautious. And I remember a quotation: "A good doctor treats one disease by many drugs, and a great doctor treats many diseases by one drug." So the more the smart the doctor is, the lower the medication prescribed. And we face problem and suffering a problem of even unethical prescription of some medications. So we should keep in mind that drugs is toxic. Drug is poisonous. All drugs are poisonous. So we should use them if they are extremely indicated. Dr. Ahmed. So it is, would you please share your slide, Ahmed?
Yes.
Yes, please. I allow you now to share. Until the slide is shared, I would like to introduce Dr. Ahmed Denewar. He is one of the very smart doctors. He is very meticulous in his care, and he also loves science and loves education. So he has a very nice character, educating himself, and he is very careful about the patient. He is dealing with patient with his heart, and I'm very proud by the presence of Ahmed Denewar in our center. Dr. Ahmed, thank you.
Thank you, Dr. Hussein. Thank you for all audiences. I'm very honored and happy to be with you today in this short talk about one of the common and facing with nearly every transplant case, which is metabolic abnormalities, including electrolyte disturbance post-transplantation. Although transplantation overcomes most of the metabolic abnormalities we are facing in dialysis patients, but new plethora of electrolyte and acid-based disturbances we are noting after transplantation. Of these metabolic abnormalities, hyperkalemia, metabolic acidosis, hyponatremia, hypercalcemia, hypomagnesemia, and hypophosphatemia are common metabolic abnormalities we are facing post-transplantation. In this short talk, we'll shed light on 3 of these metabolic abnormalities. Most of these metabolic abnormalities frequently occurring in the early part post-transplantation, mainly in the first 3 months post-transplantation, but also we can facing after 3 months. First of these metabolic abnormalities is hyperkalemia. Hyperkalemia incidence report from 25 to 44%, especially those who are maintaining on CNI. The causes of hyperkalemia post-transplantation, logically including acute or chronic reduction in the GFR, but also metabolic acidosis post-transplantation. Drugs like trimethoprim, which inhibits epithelial sodium channel, and also causing type 4 RTA, a beta blocker, which inhibits renin release, ACE and ARBs, with comparison between cyclosporin and FK. FK produce more hyperkalemia in comparison to cyclosporin, and a reports of simultaneous kidney and pancreas transplantation, the reported incidence may reach up to 73%. As regards potassium homeostasis, we all know that potassium is a major intracellular cation with intracellular concentration reaching 150 millimole per liter and plasma concentration from 3.5 to 5 millimole per liter. This high intracellular concentration is maintained by sodium potassium ATPase, which continuously pump potassium inside the cell, and only a small portion diffuses from potassium from intracellular to extracellular compartment. The body requirement ranges from 50 to 150 millimole per day. When potassium is taken, it's absorbed from the gut, after which potassium is uptaken mostly by muscle cells, bone cells, liver cells, and RBCs. And then a small part is taken after taken by the cells. It's excreted mainly by the kidneys. 90% is excreted by the kidneys, and 10% through the spleen. How kidney can handle potassium? Potassium is freely filtered from the glomeruli. After this, it's passively reabsorbed. Most of it is passively reabsorbed from the proximal convoluted tubule, and then part is reabsorbed in the thick ascending limb of Fennel. This reabsorption occurs through both paracellular and transcellular pathway. The transcellular pathway occurs through sodium-potassium 2 chloride channel in the thick ascending limb of Fennel, and then 10% is reabsorbed from the distal convoluted tubule. The first part for potassium secretion is the connecting tubule in the early part of the collecting duct through the principal cells, which reabsorbs sodium in exchange with potassium, which is secreted under the effect of aldosterone. And then only a small part in the distal part of the collecting tubule is reabsorbed of potassium and in exchange with hydrogen. How CNI can cause hyperkalemia? Cyclosporin and tacrolimus both inhibit mineralocorticoid receptor transcription and expression and causing aldosterone resistance. Tacrolimus specifically cause activation of thiazide-sensitive sodium chloride cotransporter in the distal convoluted tubule, leads to hyperkalemia and hypertension, like that found in Gordon syndrome. Gordon syndrome is an autosomal recessive disease affecting infants and early children due to mutation of the WNK kinases 1 and 2. It causes early onset hypertension, hyperkalemia, metabolic acidosis. This is associated with contracture or deformity of lower limb and cleft. How to treat hyperkalemia post-transplantation? Like every hyperkalemia, we limit use and or lowering the dose of drugs that may increase potassium levels. Dietary modification to avoid potassium-rich diet. As we said, tacrolimus activates thiazide-sensitive sodium chloride cotransporter, so addition of thiazide diuretic may be of value in controlling hypertension, especially with tacrolimus. Also loop diuretics and cation exchange resin. What about fludrocortisone? Fludrocortisone, it causes sodium reabsorption and potassium excretion in the distal nephron. It can ameliorate persistent hyperkalemia and metabolic acidosis in transplant patients. But as it causes sodium and water reabsorption, it causes fluid retention. So it can control hyperkalemia, but on the other side, it can aggravate hypertension. This is a case report published in FRCPE journal in 2016 about 65-year-old male who had decision disease on dialysis secondary to diabetes. He underwent uneventful deceased renal transplantation. His immune suppression was rituximab induction and was maintained by steroid FKMF. Started from day 1 post-transplantation. His tacrolimus level, trough level was 8 nanogram per milli. After 5 days of transplantation, his serum potassium started to increase from 5.1 to 5.7, and then increase on the day 11 post-transplantation to 6.4, despite good urine output and decreasing of serum creatinine from 10 to average 2.3 milligram per deciliter. The provisional measures is to have a low potassium diet, cation exchange resin. The potassium didn't respond and still increase. So the plan was to add fludrocortisone. After adding fludrocortisone, serum potassium was controlled, but on the other hand, blood pressure started to rise. By addition of thiazide diuretic, the blood pressure started to be controlled. And the conclusion of this study, of this case report, that aldosterone agonists can treat tacrolimus-induced hyperkalemia related to distal tubular injury, but hypertension due to fluid retention may limit this therapy, and the addition of thiazide diuretic can control blood pressure. Another case series published in Transplantation Journal in 2012 about 3 patients who also developed hyperkalemia post-renal transplantation, reaching up to nearly 10 in one of the 3 patients. And at the 7th day post-transplantation, fludrocortisone was added, and the response was dramatic, and serum potassium decreased in the 3 patients between 4 and 5 milliequivalent per liter. This is another statement about CNI side effects, which is hypertension. And a 48-year-old woman with end-stage disease secondary to polycystic kidney disease, she underwent kidney transplantation. After 1 month of transplantation, she developed hypertension. She was maintained on steroid and cyclosporin. Her PE was 148/88. Serum creatinine was 1.7. Proteinuria was 0.2 gram per day. There was no peripheral edema. Which one of the following antihypertensive will be recommended in this patient? Because the major cause of hypertension induced by CNI is afferent arterial vasoconstriction. So the first choice will be for the dihydropyridine calcium channel blocker, which causes vasodilatation in the afferent arteriole and ameliorates the effect of the CNI. The second metabolic disturbance in our agenda today will be metabolic acidosis. The prevalence of metabolic acidosis post-transplantation is from 12 to 58%. The risk is suboptimal graft function. With increasing the donor age, there is a parallel increase in the incidence of metabolic acidosis post-transplantation, irrespective of the graft function. Also, diseased donor transplantation is associated with more incidence of metabolic acidosis than living donation. With graft rejection, there is an increased incidence of metabolic acidosis, also irrespective of the graft dysfunction, hyperparathyroidism, and CNI. This is a review article published in NEDT in 2016 about 11 studies facing metabolic acidosis post-transplantation, and the title was Neglected but of Potential Clinical Relevance. The incidence and the prevalence in this study ranges from 12 up to 58% of incidence of metabolic acidosis post-transplantation, even with good graft function. What is the pathophysiology of metabolic acidosis post-transplantation? It is normal anion gap variant, distal RTA, including type 4. Immunological injury from rejection and tubulitis cause metabolic acidosis. Subclinical tubular dysfunction from ischemia. Also, as a single kidney with reduced liver mass may be associated with impaired handling of acid load, and also drugs like CNI and Bacterial. Rejection causes metabolic acidosis by decreasing graft function, but in addition to this, it reduces activity of hydrogen potassium ATPase pump and anion exchanger 1. CNI, as we said before, it inhibits mineralocorticoid activity in distal tubular cells and causing aldosterone resistance. This is a paper published in 2009 about CNI, mainly tacrolimus, is associated with transient metabolic acidosis and altered expression of the acid-base transport proteins. In case of high acid load, the kidney adapt to this by converting intercalated cell from type B, which is bicarb secreting, to type A intercalated cell, which is hydrogen secreting. For this adaptation to be happen, it needs a deposition of a protein called hensine in the extracellular matrix. This hensine present in a monomer. For its activation, it needs to be polymerized. The polymerization depends on a catalyst, cyclophilin. Cyclosporin inhibits this cyclophilin, and by turn inhibits this polymerization and this adaptation of the intercalated cells, and causing more and more acidosis. Tacrolimus causes dysregulation of the many acid-base transporters in the proximal and distal nephron, also inhibit hydrogen ATPase, sodium bicarb cotransporter, and anion exchanger 1. Trimethoprim also it causes type 4 RTA. In addition, it causes epithelial sodium channel block. Transplantation itself, as a transplantation, it decreases hydrogen ATPase expression and causes metabolic acidosis. This is a case, 55-year-old male with alcoholic liver cirrhosis. He underwent orthotopic liver transplantation. He developed intraoperative hypotension and ATN. After transplantation, liver condition was okay, and the kidney started to recover. And on the 5th day post-liver transplantation, the kidney regains its function, and synthetic function also of the liver was okay. He started tacrolimus on the 5th day post-transplantation. FK level was 14.1 nanogram per milli on the 3rd day post-transplantation. Potassium at that time was elevated, and also there was metabolic acidosis. Bicarb was 18. And potassium was 6 on the 16th day post-transplantation. This is his acid base. There was a hypercholoremic metabolic acidosis with the corrected anion gap according to field equation was 11. There was positive urine anion gap. Aldosterone level was low normal, and also renin was low normal. So the diagnosis was type 4 RTA related to CNR. The action was to add fludrocortisone 0.1 milligram and adjusting tacrolimus dose. The response was that serum potassium was decreased to 4.1 from 6, and also bicarb increased from 18 to 24, and chloride was okay, and acid base was corrected. The third and last one of the metabolic disturbance we'll face today in our agenda is hypomagnesemia. 99 of body magnesium is present in bone, muscle, and soft tissue. How kidney can handle magnesium? Magnesium filtered per day around 2,000 milligram per day, and from this, 10 to 20% is reabsorbed only in the proximal convoluted tubule. The main site of reabsorption of magnesium is the lobe of hen, which is 70%, and the remaining 10% is reabsorbed from the distal convoluted tubules. Magnesium is reabsorbed in the proximal convoluted tubule and lobe of hen through paracellular pathway facilitated by tight junction protein. Hypomagnesemia occurs post-transplantation, mostly in the second month after transplantation. How CNI cause hypomagnesemia? Tacrolimus and cyclosporin inhibits or decrease expression of TRPM6 channel in the distal convoluted tubules, causing hypomagnesemia and decreasing magnesium absorption in this part of the nephron. Also, cyclosporin inhibits epidermal growth factor, which by turn cause more and more decreasing expression of the TRPM6 channel. So it downregulates magnesium transport proteins in the distal nephrons. Also, it decreases expression of the magnesium transporter TRPM6 in the distal nephron, as we said, and decreasing epidermal growth factor production, which is the main site of active transcellular reabsorption of magnesium in distal convoluted tubule. And this causes persistently elevated fractional excretion of magnesium despite presence of this hypomagnesemia. Another cofactors of hypomagnesemia post-transplantation are steroids, diuretic use, proton pump inhibitors, and hyperglycemia. This is a case published in Turkish journal about recurrent hypomagnesemia and hypokalemia and metabolic alkalosis following preemptive renal transplantation in a 32-year-old male who underwent preemptive renal transplantation. The living donor was his sister. After 1 year, he develops nausea, vomiting, and fatigue. His blood pressure was 90/60. He denies diarrhea or use of non-steroidal or any drug causing hypokalemic alkalosis and hypomagnesemia. As regards family history, his mother has chronic kidney disease of unknown etiology, but his sister was okay. His maintenance immune suppression was steroid, FK, and MF. On physical examination, the patient was a little bit hypotensive. BB was 115/65. His vital data were okay. His laboratory investigation reveals hypokalemic alkalosis. Potassium was 2.4 with sodium 119. pH was 7.5 with bicarb 31. So it's uncompensated metabolic alkalosis. Urine analysis revealed alkaline pH of 7. The urine was blunt. Urine potassium excretion was high. Magnesium excretion was high. Also, sodium and chloride excretion were high. There was also hypercalciuria. Tacrolimus level was okay. Abdominal ultrasound reveals in the native kidneys bilateral nephrocalcinosis. The scintigraphic evaluation of the native kidney and transplanted kidney showed that the native kidney shared by 25% of the GFR. So the conclusion was the source of the problem was not the transplanted kidney. The patient was admitted 4 times in 8 months for correction of these metabolic abnormalities. And the diagnosis was Bartter syndrome in the, coming from the native kidneys. The patient was managed by amiloride, and most of these metabolic abnormalities were corrected except hyponatremia. The patient was insisted to have plenty of water intake. What are the manifestations of hypomagnesemia? Hypomagnesemia ranges from being asymptomatic complication or metabolic abnormality, or presence with tremors, tetany, convulsions, hypokalemia refractory to IV potassium supplementation, and hypocalcemia due to inhibition of potassium release. The ECG finding include pre-excitation, wave, atrial and ventricular, also prolongation of the QT interval, and peaking of T wave. There is an association between hypomagnesemia and the incidence of vascular stiffness and decreasing graft survival in patients with CNI toxicity. Also, correction of hypomagnesemia was associated with improvement of dyslipidemia, with correction of LDL and total cholesterol, with improvement of the total cholesterol HDL ratio. With investigating the relation between hypomagnesemia and insulin, intracellular magnesium regulates transport channels in pancreatic beta cells and have a role in insulin receptor phosphorylation. So hypomagnesemia may cause insulin resistance, and by turn, insulin resistance causing more and more hypomagnesemia. How to treat hypomagnesemia post-transplantation? If it is mild asymptomatic, we can only advise patients to have food rich in magnesium, like legumes and vegetables and nuts. If the patient has underlying cardiovascular disease or has previous history of cardiac arrhythmias, even with mild hypomagnesemia, we should give a magnesium supplement. With moderate hypomagnesemia from 1.2 to 1.5 milligram per deciliter, we can start with IV magnesium sulfate if patient is symptomatic, or we can start with oral magnesium if patient is asymptomatic. If severe, less than 1.2, we can start with IV then oral. Thank you.
Thank you very much, Dr. Ahmed, for your excellent presentation and using cases. We selected electrolyte disorders after transplantation because it is usually neglected and it is impossible to discuss all electrolyte disorders in 20 minutes or 25 minutes. So thank you very much. And I think we can have 5 minutes for discussion to close this session. Dr. Kossi and Dr. Ahmed.
Actually, one important thing you didn't mention, Dr. Ahmed, which is a common practice giving normal saline in the early post-transplant period. It has been shown since 2002 by O'Malley and her colleague that giving normal saline is associated with metabolic acidosis and hyperkalemia compared to Hartmann. Hartmann, in spite of you're giving potassium, is more physiological. And this work being confirmed by another 2 publications from Iran as well, which showed that metabolic acidosis can be corrected properly if you give Hartmann solution at the early post-transplant period. But actually, if you look at these papers, they're all about living-related transplant, not cadaveric, because I tried a pilot study to see whether it's going to work in cadaveric or not. Potassium actually in the immediate post-op period came back very, very high because the kidney was not functioning properly. So normal saline is not normal, and it can cause hyperkalemia and metabolic acidosis.
So I agree with this point, Dr. Halawa, and this is why we reduce or we use wise approach to limit the use of sodium chloride, because chloride is not physiological. Chloride leads to dysfunction, decreasing renal perfusion. And the sodium chloride is not isotonic, it is hypertonic little bit than the plasma. So chloride-rich fluid is not so physiological, but it is the available solution, crystalloid. So the wisdom is to limit their use, and if we use them, it's better to monitor acid-base disorder, because as you mentioned, it is one of the causes of hyperchloremic acidosis in the post-transplant. Dr. Kossi?
Oh, thank you very much. It is a very complicated issue at this time. And thank you for his excellent presentation, to be honest, to Dr. Denewar. I don't think that I need to add anything to him.
I want to add just one sentence about hypophosphatemia, because we have Professor Halawa and he is the master of parathyroidectomy. Hypophosphatemia, it is very common after transplantation, especially in the short period after transplantation, because of resistance of hyperpara or using antacids or fluids devoid of phosphate. But by the time we learn it, that mild hypophosphatemia is good news. This means that the graft is functioning and is associated with good outcome. The problem is if we have severe hypophosphatemia, for severe hypophosphatemia, we give phosphate, but in a very wise way, because if we flood urinary tract by phosphate, this may lead to acute phosphate nephropathy and acute graft function. Dr. Faisal, would you like to add anything?
It is covered very well. Thank you very much. I think this is a very important subject, electrolyte disturbance post-transplant, and the management was very nice. Thank you. Thanks a lot for the guest speakers who speak about this. Thank you.
Dr. May?
Thank you very much, Hussein. It's really very well covered, and this is one of the very
the last yes, okay. دكتورة مي اتفضل.
الواحد حاسس انه هيمشي معاه فارماسيست طول ما هو ماشي بقى يكتب الادويه بس لا this was really very well covered. Thank you very much.
Thank you very much. And the last point I want to stress upon, because I have a question in the chat. Nowadays we have a system for drug-drug interactions. Why not to use them? Yes, we use them. These are facilities that we should use. And whenever I was asked by any resident or any colleague about how to modify, I say to him, view the notebook or the computer, or because this is a facility to be used. But if we don't put in our mind, it's impossible to use them effectively. And another important point that we have here at Urology and Infection Center and I think in Western communities, I remember at Harvard Medical School, there is no license for transplantation in any center without clinical pharmacist specialized in immunosuppressive drugs. This is why I'm going to give Dr. Ala Kiwi that joined us in the generic last week, the last sentence to speak. Ala.
Hello, Dr. Hussein. Hello, my prestigious doctors. Was very informative and very good lecture. I really enjoyed it. And as Dr. Hussein has mentioned, the role of clinical pharmacist is very important in identifying drug-to-drug interactions. And we're very proud that he presented one of our slides concerning the interaction with anti-diabetic drugs. So thank you so much, Dr. Hussein.
So thank you very much for all of you. Now it is 2 hours and 10 minutes. It is quite exhaustive, but promise tomorrow morning I'm going to upload the presentation to the YouTube. Thank you all. Thanks very much, Professor Halawa and Professor Kossi, for joining this meeting and moderating this session. Thank you very much, Professor Faisal Shaheen, for joining us. We always have the pleasure to meet you on these webinars. Professor May and Professor Dawla Bilal and Professor Sami Obraya and all the attendees. Dr. Tariq Tantawi is always, I think Dr. Tariq Tantawi is the best participant because he participates in 100% of the webinars. So I think Dr. May will give you an award for this, beside the registry after Corona. Thank you all for your attendance and have a nice night. Goodbye.
Thank you very much.
مع الف سلامه. مع سلامه الله.
السلام عليكم.
وعليكم السلام ورحمه الله وبركاته.